Hello and welcome to the 2018 ABR Non-Interpretive Skills Study Guide Review Series. This is David Larson at Stanford University, and thank you for joining me again today. We're continuing where we left off in the study guide, and we're continuing in the practical safety applications in radiology in management of intravascular contrast media. So first question, how are gadolinium-based contrast media classified and why does it matter? Well, gadolinium-based contrast media are primarily classified as ionic or non-ionic and as linear or macrocyclic. In general, macrocyclic agents tend to be more stable than linear agents, and among linear agents, ionic agents tend to be more stable than non-ionic agents. Next question. Which gadolinium-based contrast media agents may be used for hepatobiliary imaging? Well, Eovist is the primary agent for hepatobiliary imaging. You have about 50% hepatic excretion at 20 minutes, although there is one unique physiologic side effect to know about, and that is transient tachypnea that can cause motion artifact on arterial phase MRI, and it's more common with high volume of contrast, 10 to 20 milliliters. Another agent that can has some hepatobiliary effect is Multihance. It has 5% hepatic excretion at 2 to 3 hours. So there is some hepatobiliary imaging possible, but primarily Eovist is the agent. Next question. Which gadolinium-based contrast media agent was recently taken off the market? That was Ablavar, which is a blood pool agent, and it was withdrawn voluntarily by the manufacturer. Next question, how are acute adverse reactions to gadolinium-based contrast media similar to and different from reactions to iodinated contrast? Well, they're different in that they occur 2 to 4 times less frequently, but they're similar in that the physiologic and allergic-like reactions are similar and the treatment is similar. So in summary, the majority of gadolinium-based contrast media reactions are mild and physiologic, including either coldness or warmth or pain at the injection site, nausea plus or minus vomiting, headache, paresthesias, or dizziness. And the most frequent allergic-like reactions are rash, hives, and urticarial reactions. Respiratory and cardiovascular reactions can occur but are rare. The highest risk, patients who are at highest risk are those who have had a previous reaction to gadolinium-based contrast media. And other lesser risk factors include other allergies, including allergic-like reactions to iodinated contrast media and asthma. Next question. What preventive measures are suggested for patients with previous adverse reaction to gadolinium-based contrast media? Well, there's no proven benefit of any pre-medication strategy, but some sites extrapolate evidence from iodinated contrast reactions and use the same pretreatment regimen. Next question. Discuss the safety of using gadolinium-based contrast media in pregnancy. Well, gadolinium-based contrast media are FDA Class C drugs, which means that there are no adequate, well-controlled studies in humans. Animal reproduction studies have shown adverse effects on the fetus, but they're relatively contraindicated in pregnant patients. Again, it's a relative contraindication. We know that that gadolinium passes through the placental barrier and enters the fetal circulation. It's filtered by fetal kidneys and excreted into the amniotic fluid, and it may remain in the amniotic fluid for a prolonged period of time. So there is a theoretically increased potential dissociation of potentially the toxic gadolinium ion. So gadolinium should only be administered to pregnant patients in carefully selected situations in which the benefit is thought to overwhelmingly outweigh the potential risk. Next question. Discuss the safety of using gadolinium-based contrast media in breastfeeding mothers. Well, approximately 0.04% of administered gadolinium is excreted into the milk of breastfeeding mothers, and then 1% of the gadolinium that's ingested through the breast milk is absorbed by the infant in the GI tract. This, of course, is much less than the allowed dose of infant gadolinium-based contrast, and so there's no evidence of any adverse effect, and there's really no need to stop breastfeeding. However, like for iodinated contrast, if the mother is concerned, they can stop breastfeeding for 12 to 24 hours after the study and pump and discard the milk produced during this time. Next question. Describe the findings of nephrogenic systemic fibrosis. This is a fibrosing disease most evident in skin and subcutaneous tissues. It may also involve other organs such as lungs, esophagus, heart, and skeletal muscles. The initial symptoms are skin thickening and plaque formation, and it can progress rapidly and may cause contractures and joint immobility. Occasionally, the disease can be fatal and there's no known effective treatment. Next question. Describe the association between gadolinium-based contrast media and nephrogenic systemic fibrosis. Well, NSF occurs nearly exclusively in patients with severe chronic kidney disease, either at a stage 4 with a GFR of 15 to 29 or a stage 5 with a GFR of less than 15. And the onset may be days to years following the administration of gadolinium. Higher doses and multiple doses of higher risk gadolinium-based contrast media are believed to increase the likelihood of nephrogenic systemic fibrosis. NSF is almost exclusively associated with Magnavist, Omniscan, and Optimark, and the few, if any, unconfounded cases have been found to be associated with the lower risk agents, which include Multihance, Prohance, Gadavist, and Dotaram, and there's limited evidence associated with Eovist, just not enough data yet for that. Next question. What other risk factors have been suggested that may predispose patients to NSF? Well, some possible predisposing factors include metabolic acidosis or medications that may predispose patients to metabolic acidosis, increased iron, calcium, and or phosphate levels, high-dose erythropoietin therapy, immunosuppression, vasculopathy, acute pro-inflammatory event, and infection. However, it should be noted that no consistent relationship between these factors and NSF have been established, and the theoretical mechanism is that there's dissociation of the gadolinium ion from the chelate with subsequent precipitation of gadolinium in the tissue, which may explain why the lower stability agents are more implicated than the higher stability agents. Next question. What precautions should be taken with gadolinium-based contrast media to avoid nephrogenic systemic fibrosis? Well, we screen patients for renal disease, and we may obtain a GFR in patients with a history of solitary kidney, kidney transplant, renal neoplasm, some say age of greater than 60 years, hypertension, or diabetes. We avoid gadolinium-based contrast media administration in patients with stage 4 or stage 5 chronic kidney disease and any patient with acute kidney disease. We inject the smallest volumes of gadolinium possible to obtain the diagnostic study. We avoid high-risk agents if gadolinium-based contrast media are deemed necessary in the patients who are at risk. And note that the highest risk agents are absolutely contraindicated when the GFR is less than 30 in using Magnavist, Omniscan, and Optimark. So we really shouldn't use these agents at all in patients with a GFR of less than 30. Next question. What does the evidence show regarding post-MRI dialysis to reduce the risk of NSF? There's no evidence that immediate post-MRI dialysis reduces the risk of NSF in gadolinium-based contrast media exposed patients. So in other words, there's no need to try to time the dialysis with the administration of contrast. Next question. In what tissues is gadolinium retained, and what is the significance of this? It's retained in the skeleton and the brain, especially the globus pallidus and the dentate nucleus, and occurs even in patients with normal renal function. The amount accumulated is proportional to the amount administered, at least with respect to the linear non-ionic agents, and retention is much greater with linear than with macrocyclic agents. But there's no evidence of adverse neurologic effect of accumulation, but further study is necessary and is ongoing. Next question. What immediate steps should be taken in the setting of an acute contrast reaction? Well, in general, when there is an acute contrast reaction, first of all, we should recognize it as quickly as possible, and then go and assess the patient and try to diagnose what's going on and treat the patient. That's probably pretty obvious. The radiologist should assess the patient, including the level of consciousness, the appearance of the skin, quality of phonation, the presence or absence of respiratory or cardiovascular symptoms, and if possible, discuss with the patient and the present healthcare providers the reason for the imaging study, why they're getting the study in the first place, description of current symptoms, and a brief summary of the patient's health problems and medications. So basically, when you go assess the patient, then find out a very brief history. Obtain vital signs promptly, secure IV access, place the pulse oximeter, and get ready oxygen. And when you do administer oxygen, administer it at a high dose. Don't just use 2 liters of nasal cannula. Note that mild reactions usually resolve within 20 to 30 minutes, but may also develop into moderate or severe reactions. So all patients should be monitored until symptoms fully resolve. Next question. What treatment should be administered for hives or urticaria? Well, in most cases, no treatment is necessary. Observation is adequate. If the patient is symptomatic, then you can administer Benadryl 25 or 50 milligrams PO, IM or IV. And if it's severe, then you can administer epinephrine. That's IM 1 to 1,000, 0.3 milliliters, or meaning 0.3 milligrams, or IM EpiPen, which is at 0.3 milliliters, 1 to 1,000 dilution, which is fixed, or IV 1 to 10,000, 1 milliliter, which is 0.1 milligrams, slowly into the IV saline infusion. Next question. What treatment should be administered for diffuse erythema? Well, like always, preserve IV access, monitor vitals, use pulse oximeter, and give O2 at 6 to 10 liters per minute via mask. And if normotensive, then no further treatment is usually needed. But if the patient is hypotensive, give 1 liter of isotonic fluids IV rapidly, and that may be normal saline or lactated ringers. And if there's a profound hypotension or it does not respond to IV fluids, consider epinephrine, again at the doses shown here, and call a code or 911 if it's severe or if the patient does not respond to treatment. Next question. What treatment should be administered for laryngeal edema? So with laryngeal edema, you're going to witness stridor or hoarseness. And again, preserve IV access, monitor vitals, use a pulse oximeter, get oxygen on board, and we administer epinephrine, again, at these doses that are shown. And this is when you want to have a low threshold to go ahead and call a code or 911 if it's severe or if the patient doesn't respond to treatment. Again, you don't want to mess around with this one. Next question. What treatment should be administered for bronchospasm? So bronchospasm is manifested by wheezing. And again, IV access, vitals, pulse ox, give oxygen. And we give a beta agonist inhaler, usually albuterol, 2 puffs, and we can repeat as necessary. And if needed, we can consider adding epinephrine. And again, calling code or 911 is severe if the patient doesn't respond to treatment. In general, if we're thinking about adding epinephrine, we probably should be calling for help. Next question. What general treatment should be administered for hypotension of any cause? Well, hypotension we're defining as systolic blood pressure less than 90. And again, we preserve IV access, monitor vitals, use pulse oximeter. And here we elevate the legs at least 60 degrees, so put them in Trendelenburg. Get oxygen going, and consider administering fluids, at least 1 liter isotonic fluids rapidly, again, normal saline or lactated ringers. Next question. What treatment should be administered for hypotension with bradycardia? Well, by bradycardia, we mean a pulse of less than 60 beats per minute, and this implies that there's a vagal reaction. So we want to give initial treatment, as we discussed earlier. And if it's mild, generally no additional treatment is needed. But if it's severe, we can give atropine, and that's 0.6 to 1.0 milligrams IV, followed by a saline flush. And just note that lower doses of atropine may exacerbate bradycardia, so you want to give the full dose. And you can repeat atropine administration of up to a dose of 3 milligrams total. And of course, as always, call a code or 911 if it's severe, if the patient does respond to treatment, or quite frankly, if you're uncomfortable managing the patient. Next question, what treatment should be administered for hypotension with tachycardia? So with tachycardia, we define that as a pulse greater than 100 beats per minute, and this implies an allergic-like reaction. So again, we give initial treatment as we described earlier, and also if it's mild, generally no additional treatment is needed. But if it's severe or continues, then we consider administering epinephrine, and again, of course, calling a code or 911. Next question, what treatment should be administered for a hypertensive crisis? Right, by a hypertensive crisis, we mean a systolic blood pressure of greater than 200 millimeters of mercury. And again, we preserve IV access, monitor vitals, use the pulse oximeter, get oxygen going, and now we elevate the head of the bed if possible, and administer labetalol, which is IV 20 milligrams slowly over 2 minutes, and we can double the dose every 10 minutes. And if labetalol is not available, you can give nitroglycerin, 0.4 milligram tablet sublingual, administer Lasix, IV 20 to 40 milligrams slowly over 2 minutes, and probably the first thing you're going to do in this case is call code or call 911. Next question, what treatment should be administered for pulmonary edema? Well, the patient's not going to tell you they have pulmonary edema per se. They're going to manifest with respiratory distress, so that's what you want to be thinking about. Of course, we get IV access, monitor vitals, use pulse ox, and get oxygen going, elevate the head of the bed, and administer Lasix, 20 to 40 milligrams IV slowly over 2 minutes. And we can consider morphine, 1 to 3 milligrams IV, which you can repeat every 5 to 10 minutes as needed. Of course, this is one where we're going to be calling a code very early on. Next question, what treatment should be administered for seizures? Well, of course, managing any seizure, we want to observe and protect the patient. We turn the patient on his or her side to avoid aspiration, suction the airway as needed, then, as always, preserve IV access, monitor vitals, use the pulse ox, give oxygen, and as any treatment for unremitting seizures, we want to administer lorazepam or Ativan. That's IV 2 to 4 milligrams, a maximum dose of 4 milligrams, and then, as always, call a code or 911 if the seizure is unremitting. Next question, what treatment should be administered for hypoglycemia? Well, as always, we want to preserve IV access, monitor vitals, use the pulse ox, and give oxygen. And then if the patient is able to swallow, we can give oral glucose, such as 2 sugar packets or 15 grams of a glucose tablet or gel, or 4 ounces of fruit juice. If the patient is unable to swallow and IV access is available, you can administer D50W at the doses shown. Or you can also give D5W or D5 normal saline at 100 milliliters per hour. The patient is unable to swallow and IV access is not available, you can give glucagon, 1 milligram IM. Next question, what treatment should be administered for anxiety or for a panic attack? Well, probably the first thing to recognize is that this is a diagnosis of exclusion, so the patient must be assessed for developing signs and symptoms of another more severe reaction, and after other causes have been ruled out, then of course we do our usual preserving IV access, monitoring our vitals, and using a pulse ox, and if no identifiable manifestations of another diagnosis and there's normal oxygenation, we consider this and just reassure the patient. Next question, what should be done to help prevent contrast reaction rebound? IV corticosteroids may help prevent short-term recurrence of allergic-like reaction symptoms before transportation before the emergency department. So we can administer 5 milligrams of hydrocortisone, 5 milligrams per kilogram hydrocortisone IV over 1 to 2 minutes, or 1 milligram per kilogram of methylprednisolone IV over 1 to 2 minutes. But note that corticosteroids are not useful in the acute treatment of any reaction. They're only used to help prevent short-term recurrence. All right, that's the end of that section. We're going to go ahead and stop there. Thank you for watching today. This is David Larson reviewing the 2018 ABR Non-Interpretive Skills Study Guide.